Wonderful. Okay, I think we are maybe going to wait a minute or so just to make sure that everybody can join and see how many folks are here. So great. Good, good. Okay. I think we'll get started and the stragglers will come in a bit later, but thank you everybody for coming to our, I should say inaugural, so hopefully first of many webinars. I'll chat a bit about myself. We'll all introduce ourselves and then we'll get into the conversation and we'll have a chance for questions at the end. So my name is Dr. Alexcis Ford. I am a urogynecologist. For those who don't know what that is, I'll talk more about that a bit later and what I do. But I work here at Advanced Gynecology. I've been here for 5 years. We are going to talk today about low libido. We're going to get lots of different perspectives on that. So low libido or low sex drive. So you'll have the urogynecologist perspective and sort of how we work that up and how we treat that. You'll have our wonderful pelvic floor physical therapist perspective as well as sex therapist perspective. So I will pass the baton here to Dr. John to introduce herself and we will get underway.
Hey, good evening. I'm Dr. Tracy John. I'm a physical therapist. I have been practicing for about 19 years, graduated from Stony Brook University, and I've been in Georgia for about 11 years. I started my mobile PT practice in 2020, so I focus on back pain and pelvic floor dysfunction, and we're going to talk a little bit more about what the pelvic floor is and what pelvic floor dysfunction symptoms are. And like I said, I'm mobile. And I service, so I come to you, I service Midtown and like the Northeast corridor of the perimeter, so more like North DeKalb, perimeter side. And yeah, that's it. So glad to be here.
All righty. My name is Erica Harry. I am a licensed marriage and family therapist. Have been licensed since for at least 17 years now. I specialize in sex therapy. My favorite area is the medical model dealing with low libido, dealing with medical issues of both men and women, such as for women, it's things like interstitial cystitis. I know that's a big word, but and for men like ED, erectile dysfunction or irregularities, delayed ejaculation, dealing with orgasm issues with women as well as painful sex. So that's what I do. I enjoy it, and I look forward to this conversation of opening it up. And I'm so honored to do this because we don't oftentimes see our Black and brown girls getting together to actually talk about this. It's such a taboo in our area in our culture. So I feel honored to do this. Thank you.
Wonderful. Well, let's go to the next slide, please. So what is low sex drive? So this is, a kind of, I think for some people, an intuitive thing. For others, you're not totally sure. What does it mean to have low sex drive? What's normal sex drive? I think there's a lot of discrepancy there. There's actually a medical definition for this. So the term is hypoactive sexual desire disorder. So basically, you have to have at least 6 months, so 6 months or longer, of a bothersome, that's the active word, bothersome low sex drive that is not explained by external factors. So I'll get into that. And then also not improved with general lifestyle changes. So I'm harping on the word bothersome because there are a lot of women, a lot of people who don't have a lot of sex drive, but it has no impact on their life at all. It doesn't bother them. And so that's not who we're talking about. We are talking about the folks that this is quite bothersome and persistent. So you can go to the next slide. So external factors. So what are external factors that can contribute to someone having a low sex drive? So I think intuitively, we all understand, being in a bad relationship, a failing marriage, we have experts who will talk to us about that, but that certainly does not contribute to a high sex drive, of course. If your partner has sexual dysfunction, of course, as Erica said, that is a huge issue where you may not want to have sex because it triggers your partner and it sort of stirs up all sorts of feelings. So not something that's really wanted or desired. Pelvic floor disorder, so that's my arena. The sort of bullet points below that all are encompassed within pelvic floor disorder. So there's all sorts, but I put a few here. Things like, chronic pain, of course, dryness. If you are having other sort of embarrassing pelvic floor issues where you don't want somebody else to be there, like leaking urine or stool, especially, issues where the pelvic floor muscles are really tight or very loose, that's sort of another area that can cause either like lack of sensation or pain. And we have another expert, Dr. John, is going to talk more about that sort of thing. And then, of course, post-surgical changes. And these can be pelvic floor surgeries. These can be hysterectomies. These can be, like, for example, dealing with breast cancer and having mastectomy and just feeling like without breasts, you're less desirable, less attractive, and then less willing to be sexual or be seen as a sexual being. So all of those things can affect sex drive as well. So you can go to the next slide. So I said I'm going to talk a bit more about pelvic floor disorders. So what are they? So basically a group of disorders that sometimes feel quite separate and have all sorts of different specialists that you could see to deal with each one of these. But when we're talking about, pelvic floor expert, a urogynecologist, this is sort of our bread basket. So different disorders that affect the pelvic floor, and they can be due to weakened pelvic floor muscles. They can be due to tears in the connective tissue. They can be due to just the pelvic floor muscles and ligaments not working properly. So there are conditions listed here: urinary urgency, frequency, leaking urine or incontinence, leaking stool or fecal incontinence, prolapse of pelvic floor organs. So basically the vaginal skin falling out of the vagina, creating a bulge that's bothersome, embarrassing. I highlighted here the genitourinary syndrome of menopause. This is not something a lot of people have heard of put in these terms, and I'll talk a bit more about that, but that is one of the biggest contributors in terms of these external factors to low sex drive, specifically for menopausal or perimenopausal women. Postpartum women also have this similar syndrome. Chronic pelvic pain, of course, interstitial cystitis, which was introduced earlier, a mouthful of a word, but basically like bladder pain or chronic bladder pain. And then, of course, mesh complications, issues from prior pelvic reconstructive surgeries. So we can go to the next slide. So what do I do? What is a urogynecologist? We are medical doctors, again, specializing in pelvic floor disorders. I went to medical school at the University of Southern California. I did my residency in obstetrics and gynecology in Boston. So you can do a residency in OBGYN or a residency in urology and get to the urogynecology space through that. And then it does require additional training though. So after residency, I came down to Atlanta to Emory and did my fellowship. So it's a 3-year fellowship where we operate mainly, so we're mainly a surgical specialty, and we operate with urologists for a year, with colorectal surgeons for a year, and then, with other urogynecologists or pelvic floor specialists for a year. And rotated clinics with them. So we get a real good sense of the pelvic floor. So the bowel, the bladder, the vagina, and how these things interplay together. And then we do manage both surgical and non-surgical issues. But primarily, we are surgeons. I'm in Scrubs where, we do surgery, but of course we see patients every day and we manage non-surgical conditions non-surgically. So that's important to know. You can go to the next slide. So I said I would talk a bit more about the genitourinary syndrome of menopause, or GSM. Folks who may be familiar with the older term of postmenopausal atrophic vaginitis. All of these words are horrible, long words, but basically they're trying to describe the changes that menopause causes on the vagina, the vulva, the urethra, the sort of skin in these areas, the way that the nerves affect these areas are all affected by menopause. So there is, I think, this misconception that this GSM or menopause causes vaginal dryness, and that's it. That is the only effect that menopause has on the pelvic floor, and that is not true at all. There is a profound effect on the bladder, profound effect on the pH balance of the vagina, so getting recurrent UTIs or urinary tract infections, yeast infections of the vagina, foul-smelling discharge, bacterial vaginosis, bleeding or bruising, all sorts of different things can be caused by the effect of low estrogen in the vagina. And specifically for our topic, for low sex drive, a lot of women who are menopausal or perimenopausal and have this real, for some women, dramatic change in terms of how their vagina feels during intercourse, it can be very distressing. And not understanding that is part and parcel of this GSM, and that it can be treated very effectively. There are over-the-counter options like lubricants and removing irritants from the vagina, but vaginal estrogen cream is the standard of care. It is very effective to prevent vaginal dryness, recurrent UTIs, all of these different things. It is, you have no idea how many people we see who, their marriage is in shambles because, the woman feels like she's broken, and really it's just menopause, and the cream fixes that all. So we do a really detailed evaluation, a history, a physical exam to check for all of these conditions that I spoke about earlier, to really ensure that there isn't something that's obvious, one of these external factors that can be corrected. So you can go to the next slide. So when we have addressed all of those external factors, what does a urogynecologist do for low sex drive or hypoactive sexual desire disorder? Education is really a big thing. I would say arguably the most important thing around this issue. The understanding that most women do not orgasm from intercourse is something that a lot of women don't know, and maybe a lot of women on this call. And it's like 85% of women require clitoral stimulation. Some studies say upwards of 90% of women require clitoral stimulation for orgasm. So, explaining that in detail, explaining that to want to have sex, women especially, and as you age, usually need more time for arousal, and that doesn't necessarily mean physical stimulation. That could mean mental stimulation. That is so, there's so much that goes into that, and I'm sure there'll be some more conversations about that, but understanding that takes time. So it may have occurred earlier before, and now it just takes longer. That's okay, and that's normal. And then, as I'm saying, these changes in desire over time are normal, and the way that you have sex over time may need to change, and that's okay. lifestyle changes. So this, I think, is just like a general rule of thumb. If you have conditions that in general make you feel sick or, detracting from your general health, they will not, that doesn't lend to a sexual being. So making sure that you're exercising regularly, your diet is up to par, trying to de-stress, like that, of course, being a sexual person means being uninhibited, being unencumbered. And if you're, bogged down by work stress and you just can't get your head off of that, sex is the last thing on your mind. So trying to understand the importance of that. And then using lots of different tools, erotica, this kind of goes into the sexual aids piece of this, where, recommending lubricants. Generally, we talk about water-based lubricants, different sorts of sex toys. We will generally recommend ones that have clitoral stimulation along with them because of, this earlier issue that I spoke about, where most women do need clitoral stimulation. And then there are lots of different websites that are really helpful. My favorite, I have no financial interest in them at all, but I love omgs.com. It is a women-based website done on evidence-based research about female sexual pleasure. There are activities you can do on your own. There are partner activities. It is hands down, I think, one of the best resources I've come across on the internet. Now, later into my portion of this talk, you can see that there are medications. There are only 2 FDA-approved medications for hypoactive sexual desire disorder. Fiblancerin, that is an oral medication, so it's a pill. And then these have like big, long generic names, but bremelanotide, it's called Vyleesi, is the trade name. That's an injection. So I will say, I have no financial interest in any of these things. I rarely prescribe these because getting to the point where we have removed every external factor and there's still an issue is actually very unusual. And that's really what these are for. And, for the women who qualify, I've had, fairly good success, but I think there's always a metric of what do we want to achieve and what is realistic from medications. And, if you have zero desire and you want to become a twice a day intercourse person, that is not what these medications will do. And I think being very realistic about the limitations of medications and how, what they can and can't do is really important. But that's a frank conversation that we would have. And I'm mentioning this very specifically because a lot of women will come in and say, like, can't you just give me a pill or something? Like, isn't there some Viagra or something for this? And that's like sort of what these are actually, like, functionally, but female sexual function is so much more complicated than male. So I think that's really important to know. And then there are surgeries. This is really like way down, sort of bottom of the barrel for low sex drive. These are typically things that are correcting these external factors. So if you're leaking during sex and that makes you not want to have sex, I can fix that. If you don't feel any sensation because of sex, because of, vaginal deliveries have really widened the vagina, I can fix that. Like that's something that I can do. If your pelvic floor muscles are really tight, you've gone to physical therapy, you've done as much as you can do non-surgically, like we can do injections in the pelvic floor to help with that. So I think that's sort of where the urogynecologist lies in this low libido universe. So of course, in this group of treatment options, physical therapy and counseling, right? So these are where I will stop, and we have experts who will talk about this and take the reins. So we'll get Dr. John to take over.
Thank you. All right. So again, I'm Dr. Tracy John. I'm a physical therapist and I focus on back pain and pelvic floor issues. So Dr. Ford mentioned pelvic floor disorders and she went over a lot of common symptoms that we see. But some of you might be asking, what actually is the pelvic floor and what does it do, right? So the pelvic floor is part of our core musculature and it is essential for our sexual arousal, our erections, and our orgasms. Okay, it is one of the most overlooked reasons for changes in sexual function. So sometimes you might think, oh, it's all in my head. Maybe it's because of my partner having issues, but sometimes it's, you know, it's an issue with your pelvic floor. So we're going to do a quick anatomy lesson. All right. So the picture on the left is showing us our core muscles. So our core on the top is our diaphragm, and the bottom is our pelvic floor muscles. In the front is our abs, our deep abdominal muscles, and in the back is our deep back muscles. So when people think about the core, most people tend to think about like their abs and they want a six pack and that's their core. The core is not just those muscles, okay? Our body's internal core is top, bottom, front, and back, okay? So all around it's like a core set. And the diaphragm works in conjunction with the muscles of the pelvic floor. So the pelvic floor muscles are, so both men and women have pelvic floor muscles, and they're like a sling. So at the bottom, you can see it looks like a sling from the pelvic bone in the front all the way to the tailbone in the back, okay? And these support and stabilize our pelvic organs. So our bowels, our bladder, our prostates in men, and uterus and vagina in women. Okay, so the picture on the right is showing us internally, if we took away all the organs, all the muscles of the pelvic floor that are inside of our pelvic bowl, which is kind of like the ring around our body. So I have a model here. So I'm going to show you where everything sits. Okay, so this is our pelvis, and in here is our organs. So this is our pelvic ring. Here, I'm showing you the women because I usually work with mostly women. So here you can see everything in red are muscles. Okay, here you can see the labia. This is the vaginal opening. Right on top of it is urethra, and then we have the clitoris. So you can see everything is really close to each other. Okay. Now on the inside, right behind our pubic bone, is our bladder. Let's take the bladder out. This is our bladder. Right behind the bladder is the uterus, right behind it. So when you might be on your cycle or you have to go to the bathroom and you get bloated, everything feels angry and you want to go to the bathroom, it's because they're right next to each other. And then right behind the uterus is our rectum. Okay, so they're very, very close. And the pelvic floor muscles help to support them, so they keep them in place. If your pelvic floor muscles are weak, then you might get pelvic floor organ prolapse, which means maybe your bladder is coming through your vaginal opening, your uterus might be coming down, all kinds of things. The organs can start coming through the opening if your muscles are that weak. Next. Okay, so like I said before, with the diaphragm and the pelvic floor muscles, if you take a deep breath in, your diaphragm goes down. So it's contracting, it's going down, and so does your pelvic floor muscles. They kind of go down and open up. So if you want to put your hands between your legs, all right, so you're going to feel down there by your vaginal area, and take a deep breath in, you should feel your ribs expand, and you should feel your pelvic floor muscles kind of relax. You should feel something go into your hand. And then when you breathe out, when you exhale, you should feel the pelvic floor muscles kind of contract a little bit and your diaphragm relaxes. So if you can take a couple of deep breaths with your hand there, or just kind of close your eyes and just kind of feel what your body is doing. If you take a deep breath in, you should feel your muscles and your pelvic floor muscles kind of open up. So it's kind of like it's breathing down there as well. And then when you blow out, they kind of come back, they kind of retract. Okay, so you can see how important they are, especially we give a lot of breathing exercises when we do pelvic floor physical therapy. So we like to use breathing because it works in conjunction with the pelvic floor muscles. And we also do all around core exercises because the pelvic floor muscles, if you tighten your lower abdominal muscles, your pelvic floor muscles are going to contract too, or they should. So if they're not working and they're not coordinated properly, then that's a sign that you need pelvic floor physical therapy, right? So trouble in the pelvic floor area may result in constipation, incontinence, pelvic organ prolapse, pelvic pain, and painful sex. So these can all result in anxiety about being intimate and cause a decline in your sexual desire and pleasure. So if you think about it, like Dr. Ford said, if you're leaking you're not going to want to have sex. If your organ's coming through your vagina, you're not going to want to have anybody inserting their penis in there, right? And if you're having pain down there, maybe because either your muscles might be too tight, then you're not going to want to have sex either. So when your pelvic floor muscles are weak or underactive, you may experience decreased sensation, or decreased arousal, and you might not want to have a, well, for men especially, they're not going to be able to maintain their erection, and they might develop erectile dysfunction, and both parties might have difficulty achieving orgasm. Next slide. All right, so to Kegel or not to Kegel. Lots of people, I'm sure you've heard about the Kegel exercise. The Kegel is actually a pelvic floor muscle contraction. So a healthy pelvic floor is correlated to a stronger and longer lasting orgasm. And also good endurance of your pelvic floor also helps with that. So the Kegel helps with underactive pelvic floor muscles, also with the core muscles and surrounding hip musculature to help strengthen. So a Kegel, like I said, is a muscle contraction. It involves squeezing and lifting. So most people, when they think about a Kegel, they think about just squeezing their pelvic floor muscles together or their vaginal muscles. And they're just like, oh yeah, I'm so good at sex, I'm just squeezing. The Kegel is actually a squeeze and a lift up. Okay, so some people, they can get like, if my finger is inserting into the vagina and I'm able to squeeze, then I'm looking for how strong the squeeze is. But you also want a lift. So if you think about, if you put your finger, if you give your finger to a baby, you know how they have that like that grip of death? You have to think about it like that. It needs to be squeezing and like pulling at the same time. So that's a true Kegel, okay? So when the muscles are overactive and they become very tight and they're difficult, if you have difficulty relaxing, that can lead to painful sex, right? Discomfort with penetration and pain if you do happen to have an orgasm during that time. So in this case, the Kegels are not effective. So they're not the go-to exercise for everybody, right? Because they can actually make it worse if you're already tight and you tightening them more when you're doing a Kegel, that can make it more painful and that can make the symptoms worse. So that can, you can even lead to some tears. It can lead to more anxiety. All right, so how do I help as a physical therapist? So I use manual techniques. So first of all, when we do our assessment, the gold standard is an internal exam. So think about just like you're going to the GYN. I'm gonna get some gloves on, I'm gonna put lube, and I'm going to palpate your outer area, the external areas, your vulva, and everything around there, and make sure there's no skin discrepancies, no rashes, any pain when just touching on the outside. And then I'll insert my fingers and there's 3 layers of the pelvic floor muscle. So I go through each layer and go around and check if there's any tenderness, if any scarring from any surgeries that you might have had, anything that's abnormal. And then I'm going to ask you to do the pelvic floor contraction to see how strong it is. And I also want to make sure that you're able to relax. I want to make sure that you're able to coordinate the contraction and the relaxation. So we use manual techniques, so like internal massage. So we use special tools like what do you call it? Like the pelvic floor trainers, magic, like the wands that we can train you to use so you can do your own internal treatment. There's biofeedback, electrodes, there's different things that we can use. Vaginal dilators, if you're tight, we can use them starting from as small as a pinky. They look like dildos. They're like as small as a pinky is the first one we'll use, and then we'll kind of gradually go up to just help your muscles relax, and also use like the breathing techniques and give you stretches. So you can get tight muscles, and you can have scar tissues. The scar tissues might be from abdominal surgeries, if you had bowel resection, any GI issues, C-sections, hysterectomies, because those can all refer pain to your pelvis and your genital area, because those are, the abdomen is part of your core and it's very close to your pelvic floor muscles. So the techniques we use are to help with blood circulation, help relax the muscles, the tissues, And those can help in turn help your sexual function. So some of these symptoms can cause anxiety and depression, and it is recommended that we also, use mental health experts to get involved, because sometimes when you have these pelvic floor issues, it causes more mental health issues, because some people perseverate on, oh my gosh, I'm too tight, I'm too tight, I'm too tight, I need to relax all the time. And some people are perseverate on the fact that their organs are falling out or they're super weak. So it causes all kinds of other disorders. So that's when we call the mental health and sex therapist, because the mind and body need to be coordinated to ensure that you have a healthy sex life.
Thank you. Thank you, Tracy, for a neat introduction. I appreciate that. So, with sex therapy, of course, so let's talk about sex. Let's get to the to the good stuff, good stuff. So, how can a sex therapist help? Well, in sex therapy, when you come in and you say, "Hey, I've had painful sex, I don't know what's going on, or I don't feel like having sex, and I haven't felt like having sex for a long time," we're going to do a biopsychosocial and spiritual assessment in terms of low libido. Now, a biopsychosocial social assessment encompasses me speaking, me talking to you as a client and being able to determine, have you met with a gynecologist? Have you met with a pelvic floor therapist? Have you met with um, all the other practitioners that encompass the assistance in terms of low libido? In addition, I also do spiritual assessment, because oftentimes I do have clients who have been a part of the purity culture and they wait. Sometimes my clients will wait to have sex and realize that in the purity culture, they don't have what Dr. Ford was talking about earlier. They don't have a lot of education. And so they get in this sexual space and it's like, uh-oh, wait, I thought sex is supposed to be great. And so you move from, don't have sex into have as much as you want. But if you don't have enough education, pain is more likely to happen. And then as a woman, we often say, pain and sex does not equate in our brain. So like I don't want to have sex. So we will establish we'll do a biopsychosocial assessment. We'll establish a treatment plan somewhere between um 3 to 4 sessions, and that depends on if you come in as an individual versus coming in as a couple. It takes a little longer to have for the treatment plan to be established if you come in as a couple. And then, during that assessment time, I will do some referring out to medical specialists such as Dr. Ford. Um, I will hold off on Dr. Tracy, and I'll tell you why. Because with pelvic floor therapists, they are on go. So when I send you to Dr. Ford's going to have you doing physical things. So what I want to do as the sex therapist is really give attention to those things that they talked about earlier, such as anxiety, depression, if you've experienced any type of trauma. We want to be able to make sure that we're pairing these the medical as well as the pelvic floor therapist in the right timing and space. So we also help individual and couples develop a psychosexual communication skill. So we talk about something that Dr. Ford talked about, erotica. We talk about pleasure. Uh, and so what we do is if a female comes in and say, "Hey, I'm having low desire or painful sex," we're going to pause on the problematic behavior so we can get a clear view of how your mind and body are working. And simultaneously, once we get those assessments and that treatment plan going, then we simultaneously work with a pelvic floor therapist to actually target the physical portion while we're still working on mind and body together. Before we get into the problems of low libido, I think it's important to really define what sexual health is. And it's I'm going to read this because I don't have this off the top of my dome, okay? So it it is a state of physical, emotional, mental, and social well-being in relation to sexuality. So sexual health is not merely the absence of disease or dysfunction or infirmity. Sexual health requires positive and a respectful approach to sexuality and sexual relationships. In addition to that, also you want to have pleasure and you want your sex to be safe. You want your experience to be safe. You want to be free from coercion. Of course, you want to also not have discrimination and violence. So, for sexual health to be attained and maintained, sexual rights of all persons must be respected, protected, and fulfilled. So, in order to have sexual health, is not just a matter of not having a low desire or disease or dysfunction. It's actually adding those other things such as pleasure, lack of coercion, which we call consent, because sometimes we get in these long-term relationships, and sometimes there are times where our consent is not received, and we get into a negative space with our partner, and so it frankly it messes with our desire. And so as we look at those things, we want to make sure that um, we're not just thinking of, oh well, it's just, the low desire. We want to have good sexual health overall. And so in terms of sex therapy treatment, sex problems, we can move to the next slide, are often symptomatic, of course, of some either individual and or relational health. And so what we do is we actually reframe the sexual problem as an opportunity for growth in the way that benefits both the relationship in terms of intimacy and the person's sexuality. So when we look at sexual treatment, we try to integrate mental health challenges that you may be going through with there are different types of therapies that we use, such as attachment, psychodynamic, cognitive, and behavioral therapies. So we use a multitude of therapies depending on our client's situation and concerns that they have. Next slide. Um, I love this model, by the way, you guys. So this model of treatment, it talks about the sexual response. So when we have low desire, we have what is called the dual control model. And we liken it to think of a brake pad and an accelerator. So things that accelerate our desire is feeling love and being able to bond with someone. It's being able to understand our partners or a person's erotic cues and visual cues. And it's the ability to receive and accept those romantic gestures. So that tends to get our jets going. The things that tend to inhibit us or put us in break mode is one of the biggest things for us women is how we feel about our bodies, uh, our our image, as Dr. John was sharing earlier. When we have a prolapse, we're not feeling confident. We're not feeling comfortable in our own skin. So as a result of that, we tend to put the brakes on in terms of I don't feel like it. We think of also that puts brakes on us is our reputation, how we feel about ourselves, how we feel that our partner feels about us, what perception is out there about us. Are we feeling used by our partner? Do we feel like we're just, I'm just a toy to you. All you think of is sex, and it's not necessarily about me. Feeling accepted. Do we feel accepted? If we don't feel accepted, we're going to put those brakes on. And as Dr. Ford was speaking of earlier, stress is a big, big part of how we put the brakes on when it comes to sex. If we're stressed out, as she said, it's the last thing on our mind. And also our mood. In terms of our mood, if our mood is not in a good place, if we're, we might be s- getting ready to start our period or in the middle of our cycle and we don't want to be bothered. So there may be a mood, there may be some moodiness going on. In addition to that, or we might even have a mood disorder. If we have some mental health disorders, those things could actually put the brakes on us. And finally, our sexual history. Oftentimes, we really struggle when we have a negative sexual history. It really can challenge our relationship, current long-term relationships, and it challenges our sexual connection. So, as a result of that, it's real important that we pay attention to the breaks. And a lot of times people think that it's, well, I don't have enough love for the person, or maybe I've fallen out of love, or maybe, they're erotic cue, or I'm not giving enough erotic cues. A lot of times we believe that it's our accelerator that we need to keep pushing on. Like, okay, well, maybe I just need to do more sexy stuff, or maybe I just need to um try a different way of being connected, when really one of the ways that we can address that low desire is taking our foot off the brake. So these things that are breaking our connection in terms of a desire, such as the feelings that we have about our body, those are things that we need to address so that you can feel comfortable and confident and bringing that to the bedroom. Um, Next slide. So some of the tools that we use for low desire and arousal, as I spoke before, is education, um, and really normalizing certain things. A lot of times there are two types of desire that we have. We have spontaneous desire and we have responsive desire. And as Dr. Ford spoke earlier around women and arousal, it there's a huge orgasm gap between men and women. And that's, I will tell you, that's one of my passions, but that's for another webinar. And we could talk about that for an entire hour. And because the gap is so huge. Uh, um, so there's spontaneous desire and there's responsive desire. Oftentimes, as women, we have more responsive desire. So we tend to piggyback on certain things. So we need that emotional connection. We need you to tell us certain things so that we feel connected to you. If we don't feel connected, oftentimes it's like, we'll take it or leave it. Um, we will also want to, oftentimes we need to take the focus off of intercourse. A lot of times we focus in on, we got to have intercourse. We call it PIV, which is penis and vagina sex. We got to have PIV. And we need to broaden our repertoire and reduce that goal directed sex. We got to get to the orgasm. The real deal, and what we find that the real deal is in pleasure and understanding pleasure. So we do a lot of educating of the body, educating of the mind, and how to make those connections. Um, Prioritizing time for sex. Oftentimes, couples try to say, let's have date night. And if you have low desire, right? How much, how much time are you really wanting to have a date night? Because you automatically know in your head, date night means they're gonna wanna have sex. So it's like, I don't really wanna put too much time on date night. So there's a lot of pressure for that. So some of the things that we really work with, the tools that we work with is something called Sensate Focus. It's a exercise of non-demand pleasure. Now, we can get into that again, for a whole nother webinar. But sensate focus really takes the pressure off of actually being sexual, and it focuses in on the body. It focuses in on touch, on the temperature, the pressure of your body. So it looks at doing a pleasure exercise, is what we call it, and it's non-demanding. So at the end of these exercises that we give you, no sex is involved. I know guys who showed up today, don't don't jump off. There's more. So we also screen for any intra or interpersonal issues such as relationship conflict, trauma. Trauma is a huge one. Um, any trauma history, any caregiver role, or any fatigue, that exhaustion, tiredness, all of that plays a part in low desire. So we really focus in on giving you tools necessary to address the trauma, to address the fatigue, to address the stress, and again, making sure that we do that mind body connection. Sexual knowledge is important. The values and the beliefs that you have. Sometimes we value things, but then we may have a what we call a moral injury. Like we are told, don't have sex before marriage, but then we experienced a moral injury with that because after we learned that, okay, it didn't really work for us. If I feel like I've done everything I'm supposed to do and it's not working for me, that could really um, it could really weigh on your self-esteem. It could really weigh on your body image. So we really focus in on providing sexual knowledge to our clients. We also do bibliotherapy. So we give you things, articles and things to read. We also, and if necessary, we will refer to a couple's counselor in terms of, for instance, if you're coming to me as an individual and you say, I want couples counseling, then I have to refer you to a couples counseling. So I wanted to make sure that was clear, although I do couples counseling and sex therapy. So, luckily you get two in one if you come as a couple. Next slide. So I'm going to hurry this on. We have a common intervention we call the good enough sex. Now, I know you're like, good enough sex. Who wants just good enough sex? Well, what happens is over time, we have sometimes we have good sex, sometimes we have bad sex. You know, I I I asked the guy, I said, "Have you ever had bad sex?" He said, "No, if I'm having sex, it's it's never bad for me." So, so, but sometimes as women, because there's an orgasm gap, like we talked about earlier, sometimes there is bad sex. So there's bad sex, there's good sex, and oftentimes there's great sex. So one of the things that we talk about and we work on is having good enough sex. So, but you have to come to therapy for that. So, so one of the things that we also, thank you, one of the things we also really focus in on in therapy is really resetting your mindset. So if you've experienced trauma, then we have to move you from a trauma slash sexual performance mindset to a pleasure mindset. Well, what does that mean? We all grew up. We have all grown up in a performance mindset. If you live in America, everything is about how you perform. They just started these last couple of years giving out participation awards. But Do- Dr. Ford didn't get a participation award in medical school, I can guarantee you. And Dr. Tracy did not get a participation award in physical therapy. So we have these mindsets that we have built up, like we've got to be perfect, or it's a pass fail, it's fail succeed. Either we had an orgasm or we didn't. There's a lot of pressure, there's a lot of guilt. So in the performance mindset, as you can read these things, it can be very demanding. The expectations are high. If the expectation is super high, then that causes us to be disappointed when we don't get it. It's like, oh, I like this guy and I love this person, but I didn't get an orgasm, so now I'm disappointed. Well, why did we make orgasm the goal in the first place when pleasure should have been the goal? So on the pleasure side, what we do is we help your mindset to expand to looking at intimacy and sex and being flexible and being curious about things and being more inviting, adaptive and being accepting. Um, and also we use a lot of humor. So we want you to be, sex can be fun or sex can be not fun. And then you can laugh at it like, oh, darn. And the big thing about pleasure is you have to have compassion because when you're intimate, some things won't go well. But if you don't have compassion and you're more critical, you're more likely to sustain a lot of anxiety. So helping you get out of your head and be present in the moment is real important. Next slide. Uh, we talked about sensate focus. That's an exercise. I want to wrap this puppy up because I want people who have questions to go ahead and ask their questions. But sensate focus is another one of those exercises that's really detailed, really intense as you go along. And the goal is pleasure. The goal is not sex. Next slide. And so we also give a homework assignment is for couples, we do the Our Touch menu. So we have you write out what's affectionate touch, what's sensual touch, and what's genital and erotic touch. So we define these things and then we go into how we help the couple to verbalize and talk about sex and communicate about their sexual how they want sex to look, how they want their intimacy to look. So not just sex, but how do you want intimacy to look across the board? In addition to that, we talk a lot about affection outside of the bedroom. So for women, we need our mind stimulated. So our mind could be stimulated at the front door when you give us that good morning, goodbye kiss, and that hello and welcome back kiss. It's not just the peck, like you do your mama or your dog or, your niece or your nephew. It's a full on give me 5, 6 seconds of I'm going to hold you and wrap you in my arms and let you know that you are cared for and you are safe. That's what oftentimes women need. So, with that being said, our presentations are done, and I'm looking forward to anybody who have any questions. Do we have any questions placed in the chat so we can answer them?
We do. I actually think this is probably a wonderful one for you. And I'll kind of paraphrase, but basically we have a woman who I know well. She had a pelvic reconstructive procedure with me 4 years ago. She has not had sex yet since the surgery. And I'm quoting, I am nervous and scared to have sex. I want to have it, but I'm afraid to use it. What should I do? Because I don't want to be the last 53-year-old post-revamp virgin. Oh my goodness. Yes,
So,
yeah.
so again, I think coming to sex therapy to really get a better understanding of your anxiety, because what's happening is you're already in your head about what potentially could happen. And so going back to when we go back to the slide of that mindset where we have that performance mindset, it sounds like anxiety is really taking over. So we really need to slow your brain down and figure out how to make that connection of your brain going into dealing with the actual penetration. Of course, if you haven't had any pelvic floor, we will work on your anxiety and we slowly introduce pelvic floor therapy
Indeed.
before before we before we introduce da, 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 here comes the penis.
Yeah.
So I hope that helped.
Yes, I agree. I agree with Erica. Yeah, we need to get your mental wrapped around, um, getting your vagina wrapped around. And then, an internal exam would be beneficial to just make sure that you don't have any hypersensitivities or any aversions to having penetration done, and go from there.
Okay, wonderful. Some more questions, and I think I can field this unless Dr. John, you want to, but this is about lubrication or lubricants. So the question is, what about Replens, which is a brand name of a sort of personal daily lubricant, or any over-the-counter lubricants? As far as I'm concerned, when we talk about lubricants for intercourse specifically, we usually recommend water-based lubricants. Replens is again, more of like a daily lubricant that is separate from intercourse. It can be used, but in general, it's not really designed for that. But if you're using a water-based lubricant, you're pretty much okay. There's a brand that I like. I think that the consistency is the best. It's called Swiss Navy, but there are loads of other kinds, and I think you sort of have to experiment and decide
Yeah,
on your own.
I agree. I agree. There are different brands. I mean, when I'm in the clinic, when I use lube, I like, my favorite is Uber Lube, and I do give samples out to some of my patients. And then there's also slippery stuff that we use, that are more not water based. I don't know why it slips my mind right now, but oil based, and I forgot the other one right now.
That's just slow. Mm.
Might be
Sorry,
silicone based.
silicone based. Thank you.
Okay.
See what this
I think
question is.
the next one, how does hysterectomy affect one's libido? That is a wonderful question. Sorry, I'll say that slower. How does a hysterectomy or removing the uterus affect one's libido? So I think I should emphasize that hysterectomy means removing the uterus, period. There's a bit of sort of misconception there that hysterectomy means removing the ovaries also. That is not what a hysterectomy is. So if we're talking specifically about removing the uterus, this has been studied. There are, I would venture to say, several hundreds of studies about this specific topic. And recently, like in the last couple of years, I read a meta-analysis which tries to look at the best of those studies. And over, we see that removing the uterus, whether or not it's a total hysterectomy, so removing the uterus and the cervix, or a partial hysterectomy or supracervical hysterectomy, leaving the cervix, really does not affect libido. Where we do see libido affected is removing the ovaries, especially in a premenopausal woman, because the ovaries are the progenitors of hormones, right? Of your estrogen, of testosterone. So there is a profound effect there. You will find a lot of women who have the hysterectomy alone, so their ovaries are still there. Temporarily, they can have a decrease in sex drive, and that is mostly associated with external factors, so pain from the procedure, bleeding, etc. Other things that would make you not want to have intercourse. But from a hormonal standpoint, no, there's no affiliation there. And then there is another question for me. Does insurance cover any of those surgeries? Insurance covers all of those surgeries. So yeah, they're not considered cosmetic or anything. And this question for Dr. John. Dr. John, do you ever offer services outside of your service area, particularly Cobb County?
I will go outside of my service area, but there will be a travel fee depending on how deep into Cobb County you are. If you're just like in Marietta, like closer to the city, then perhaps like I would go there, just depending on the flow of traffic.
Okay. Thank you. Another question, is there an age when one's libido should naturally taper off? So no, there's no age. I think when it comes to hormones, and if we look at like lab draws that you can have to see if you're menopausal or premenopausal, like that actually correlates very little with actual sex drive or libido, in the same way I have a lot of 80-year-old women who feel just as active as they were when they're 20. There's not an age cutoff. I think naturally as we age, it lessens, but that's not a rule, and there certainly are no strict cutoffs in terms of age. We do know that menopause, which can happen at lots of different ages, but that can be sort of a cliff for some women, but for a lot of women it's not. So no, there's no rules in terms of the age. Another question: I've experienced migraines with onset of an orgasm. What's that about? And migraines are not sexy. Okay, yeah. Okay, that's a really great question also. I think the precise physiology around that is not, I don't think you can get a perfect answer, but in general, what is an orgasm? An orgasm is like rhythmic contraction of pelvic floor muscles. Preceding that, though, with sexual arousal, that usually requires dilation of blood vessels, right? You get more blood flow to the clitoris, like for biologically male, to the penis, right, to create an erection. So engorged blood vessels or dilated blood vessels, and then this rhythmic contraction. So migraines are caused by blood vessels that are spasming. Migraines is a pretty specific thing, but you can extrapolate that to just headaches in general. So you can have headaches from enlarged blood vessels that are going to the brain and causing pain. So is there a connection between the blood vessels in the pelvis and the blood vessels in the brain? I mean, probably, but you know, you're not the first person I've heard say that. I think maybe a neurologist would have a better, more precise answer than me, but it certainly is a connection surrounding blood vessels and the spasm of blood vessels. So that is interesting. If that is something that is stopping you from having sex, that you should see a neurologist. That would be definitely the person to see first about that. I think that is it for our questions. It is a little past 7 o'clock. So unless there's anybody else, I don't see any last minute questions coming in, but I just sincerely, on behalf of myself and the group, just really want to thank everybody for participating today. Our contact information should be distributed, and I think was distributed. So if anybody wants to get in contact with us, schedule appointments, consultations, you should have that information. We are normal, nice people, and we're really happy to help anybody who needs help. So thank you guys for attending.
Yes, thank you so much, everyone.
Thank you guys. We appreciate you, and thank you for showing up to our beautiful webinar.
All right, take care. Bye-bye.